and welcome to our COVID-19 and beyond webinar with the big support of SonoScape. I think we're all suffering from the COVID-19 disease now since many weeks and in some countries even since many months. And it's a really great pleasure that you're all with us here on board. So we have over 140 participants at the moment streaming from all parts of the world. And I'm Helmut Neumann from Germany, and for us it's now 2 p.m. And we have also very distinguished guests today, fantastic speakers from all parts of the world. And in this context, it's now my very, very great pleasure introducing Professor Ding, Professor of Medicine from Wuhan, from China. And Professor Ding, I remember we have discussed in February this year, the first time about COVID-19 when I was in Thailand. And during that time, there was not so much spread of the virus in the world, but you have already fight a lot against this. And we all acknowledged the massive fight of you and your team and the Chinese people in general, giving the rest of the world so much time to prepare. So it's a great pleasure having you here, and we are so much looking forward to your talk later on about development of COVID-19 and your experience, which is definitely the biggest one, because it seems that it might have been started in Wuhan. So again, a fantastic, great pleasure having Professor Sharma here, Pratik Sharma. I think he's one of the most well-known endoscopists in our field doing endoscopy since I started my career. He is a governing board member of the American Society for Gastrointestinal Endoscopy and professor of medicine at the University of Kansas. It's a great pleasure having you here with us, Pratik, on board. It's always fantastic talking to you and to learn so much from you. Also a very great pleasure, and by the way, in the United States, it's now early morning, 8 a.m., what I've learned before. But the same time for me is for Professor Hassan. Cesare Hassan is also professor of medicine from Rome in Italy, and he's also fighting the COVID-19 pandemic since the first time in Europe. He's governing board member of the ESGE, the European Society for Gastrointestinal Endoscopy, and I think it's definitely up to him that now in Europe we are leading with our guidelines, because this is what you, Cesare, has organized during all the last years. Also, great pleasure introducing Professor Mark Anthony De Lusong from the Philippines, also professor of medicine and a good friend. And it's fantastic having you here with us on board and discussing about COVID-19. And I think in this webinar, we'll definitely answer all of your questions. So at the end, no question should be not answered. So if you want, you can always contact us with a chat function, and we'll try to incorporate your questions for us as well. And then also, of course, finally, it's an absolutely great pleasure having Professor Mahesh Goenka here from Calcutta in India, professor of medicine and director of the hospital there. And I had the very great pleasure and honor meeting you and your wife last year at the APDW in Calcutta. It was a fantastic experience, and it was in December last year. So we have organized a lot of questions for you, because again, the aim of this webinar is that at the end, there will be no open questions anymore regarding COVID-19 and endoscopy. And I think we are all aware that it is now time for us to start endoscopy again. We should not wait that much anymore, because the patient definitely needs us. And again, before we start with a lecture of Professor Ding, again, I need to thank SonoScape, company from China, very much engaged in advanced endoscopic imaging and advanced therapy, and also not only on endoscopic therapy, but also very much interested in sharing knowledge and education, as we can see today, for organizing this, this common mutual webinar here. So Professor Ding, so when you're ready, it would be great if you can share your desktop, please. And then if you unmute your speaker, please. And then we can already see the slides. And if you can now please unmute your phone.
Okay.
And now we can see the slides and hear you. Thank you so much again for giving us this very great pleasure.
Okay. Thanks the chairman's introduction. And I'm Zhen Ding from Wuhan Hospital. Today is my pleasure to get the invitation from the SonoScape Medical, the Chinese endoscopy industry leader, to take part in this roundtable to share our experience or some information during the outbreak of COVID-19. Actually, my focus have left the COVID-19 for a long time. So for this lecture, I try to find the world epidemic maps and to see how many persons get the infection and how many lost their lives and how many countries are involved in this crisis. And this picture is today's Wuhan city. And we can see even almost everybody have the mask, but their expression looks relaxed. And it's hard to imagine only 3 months ago, our country and our city is facing a dark time. And at that time, everyone's expression looks very serious because Wuhan is the first severe involved city in this crisis. So we don't know how long of the time and how much we have to pay in this event. So this picture is I take on February, and we can see the low person on the street. And it can see this is the our city after lockdown. So it looks lost the Virgo. And this week we get another news and to indicate, to remind us to how dark of the time is. And the Xiaoxia Liang is a nurse from the Southern Chinese medical team, and she sacrificed her life on this Tuesday. Actually, on the February 28th, she fought faint in the front line in Wuhan in our hospital. But the reason is not the infection of COVID-19. And I will tell the reason later. Okay, so this I think this is another indication to us to we have to focus on how to protect ourselves during the outbreak. Before I answer the question, we have to learn the transmission route of the SARS-CoV-2. We all know this virus can transmit by air droplet and close contact. But the close contact is much more than body surface contact, because this virus can survive in the smooth surface for several days. So if we touch a contaminated surface, for example, the stair arm side, the door knob, and the elevator button, we might be infected by the SARS-CoV-2. And except this way, there are some possible transmission routes. Chinese researchers have isolated the virus from the patient's stool. And in this publication, we can see the ACE2, the receptor of SARS-CoV-2, and some other virus protein can express in the GI tract from the esophagus to the rectum. So the fecal-oral transmission is possible. And in this study, we can see the researchers get the nucleic acid from the patient's tear sample and the conjunctival secretions. So conjunctival secretion is also the transmission way. So we can conclude the endoscopy unit staff are at high risk of transmission, because in the procedure, we might be infected by the virus by the inhalation or contact some contamination fluid. And how to protect ourselves? I try to answer this question from the patient screen and the staff protection. And as to patient screen, during the outbreak of COVID-19, we should pose the no essential endoscopy procedure And the procedure can only be used in the emergent case, such as GI bleeding, the foreign body in GI tract, obstructive jaundice with infection, the biliary acute pancreatitis, and the feeding tube placement. And before the procedure, all the patients should get a screen, the temperature, CT scan, antibody, and the nucleic acid detection. Even now, all patients should get the screen before the procedure in our city. And if all the results are good, they can go to endoscopy room for the procedure. If they get the infection, they have to be sent to the negative pressure zone in the for the procedure. And actually, not only for the procedure, all the patients in the hospital in our city for procedure or for hospitalization, they have to get the screen, all of this. Okay, so as to the staff protection, first we have to check ourselves, just like the patients, the symptoms. If we have the suspected symptoms, we have to isolate ourselves for further examination. If everything is okay, we can go to work. And the PPE is very, very important. And this picture shows the different level of PPE. If the patient have low infection, the level 2 PPE, the protection is enough. And if the patient have infection, the level 3 is better. And this shows the different level of the PPE. The level 1 means medical staff have the medical cap, mask, gloves, and working clothes. The level 2 is level 1 plus the gowns, the eye shield, and the shield cover. And the mask should bury the virus. Yeah, the N95 is better. And as to the level 3 protection, the medical staff is level 2 plus the double gloves and the mask respirator. And this I got the two pictures from online. The left picture shows the Chinese doctor is working with level 2 PPE. So after February, it's rare to see the Chinese medical staff get the infection of SARS-CoV-2. And this picture is show we can see the doctors is working in the front line, but the protection is not enough from we can see the leg and the shoes. So if we continue our work in this situation, I think the infection, the transmission is unavoidable. So this is what the picture about our working. We work in the outpatient center, and this is we cover our body surface from head to toe, and this is added ERCP with the level 2 protection. And we can use some other new instruments. This is we use the disposable endoscopy. So the image is good, and this is the introduction of this kind of endoscopy. And this is the progress is about how to put on or the remove the PPE. Actually, I think is a little complex, especially to a beginner. So even we repeat this progress a lot of times. I think at the beginning we have a lot of possibility to make mistakes. So our experience about this the first we have to set a watched person, a trained person to watch. So if you make mistake, they can point it out right now. So I think this is very, very important because especially when you remove the PPE, any mistake may cause the infection. And another point I have to address is we have to set a separate region between the contaminated region and the clean region. This region can complete the step 5 to 10 of the removing the PPE. And the third is do not work along with PPE for a long time. This is the in this point I have to indicate why the Xiaoxia sacrificed her life, because she died of hypokalemia. And why? The reason I think we just to guess the reason, because on February the PPE is not enough, so all the medical staff want to save the PPE as much as possible. And if we have the PPE, it's very, very difficult to go to nurse room. So someone want to avoid the restroom, so they stop eating and drinking before the work. And but you know, the work with the PPE is very, very hard, and you may be sweaty and to exhaust the power. So a lot. I think more than one medical staff fall faint, but almost almost the case, sorry, almost the case were found and treated right now. But the Xiaoxia fall faint on the separate region. So we know in that region, only we stay in that region only for put on or remove the PPE. So it's unfortunate at that time, only she stay in that region. So after this case, after this accident, we make a new lunar. No one can stay alone with PPE anywhere. Cannot stay alone. So this, I think we should get some experience from this case. So in this crisis, I think the global medical staffs have shown our spirit, our bravery, and our power. And but today I want to say what we need in this crisis is much more than doctors and nurses. Because even every medical staff as Superman is not enough. Because I think at the beginning of outbreak, everyone have the same feeling. The more patients we treated, the more new patients we have to face. So I think the transmission route is much more important than treatment a single one. So how to break the transmission route? It's easy to say, only 2 steps, the test and find all case and isolate them. But it's needed the powerful social management and the cooperation from everybody. So in our city, I think we get the staged success because all citizens are fighters. So we get this only because of our union and cooperation. A doctor to treat the patients for fighting, and the patient get the treatment also for fighting, and someone stay at home, and someone deliver the supplies for others can stay safely. So I think because of our union, we can get the stated success. So I think in this crisis, no one or no country can sustain the safety alone because we live in the same planet. And even now, we still have to face the risk of the second wave of infection. So if we want to get the final success, we have to union and cooperate. So in this, we can get the final success. Thank you.
Well, thank you very much, Professor Ding. This is a very exciting talk and very important for us. And first of all, of course, I also have to thank you for fighting the disease since the very first time. And you have already shown the pictures from Wuhan a couple of months ago. But of course, those empty streets, empty shops and everything, this is what we have already now seen in all of our countries. And that's the reason why we're all here. And we have now over 260 participants from all parts of the world. So really the whole world is suffering from it. So Professor Ding, may I ask, what is the current situation in China? Because we are learning that mostly it's only imported cases, what you have now. And of course, this gives good hope for all of the rest of the world so that one really can fight the pandemic until the end. What's the current situation for you at the moment?
Yeah, I think in China or in our city, the situation is similar because till now we don't have the much more new confirmed case, and almost all new cases are imported case. So, so I think the the key points of to avoid the risk of second wave infection is to manage the new imported person and to test and to find on time and to find the infection on time. So it can it is the most important things we need to do now.
Thank you. So, Cesare, Professor Hassan, from all the European countries, Italy was one of the very first one getting very, very much affected by the COVID-19 disease. And we have seen the dramatic images and the help and the scream from the healthcare system. What's going on at the moment? Is it already getting better in Italy?
Yes, in Italy, as probably in China, in Wuhan before, we did a 3-month lockdown. So everyone was at home for 3 months. Did it work? Brilliantly. Most of Italy now is at virtually zero or very close to zero cases, with the exception of Milan, where the outbreak was so terrible, but so terrible, that it will take 2 more weeks. But Helmut, let me clarify something that is very clear to Zen and to all Chinese, but maybe not less to Europe. The fact that we don't have new cases every day doesn't mean that we eradicated the virus. The virus is there, and the risk of a new surging of the infection is present, as it was last week when we had 5 cases per day. So what we need to do, like the Chinese endoscopists, is to continue in a rigid infection and prevention control strategy. We should not relax only because now we read zero on our newspaper. If not, it will be a mess. So what I recommend at this stage is still to be extremely cautious. You don't need to go back to 100% full capacity because you read there is 0 cases. So please continue what we are doing because we are doing well, but you don't need to stop now.
I think this is very important because we all know that COVID-19 will not only be in 2020, but we'll definitely deal with the virus even for the upcoming years to come. But we also know that we have to come back to reality, to a very safe reality and a new reality. But definitely we have to come back because we see how not only our patients are suffering, but of course, even our business and the economy in general. So Professor Sharma Pratik, so United States was also very much affected. One of the latest countries, so Europe was a couple of weeks before, but then there was a major outbreak in the United States again. So what's the current situation in US? So from the media, there is it's sometimes very difficult to identify what's really going on now in the US. But this is, I'm pretty sure, not because of the media in US.
Yeah, thanks, Helmut. So the cases are still increasing, and it just depends. I mean, again, the US, just like Europe, I mean, it's a huge country. So it's all region based, and whether you're on the East Coast or the West Coast. So it started off mainly on either coast. And fortunately, us being in Kansas City, in the heart of the US, the cases in the Midwest have been relatively low as compared to New York and to California. But nonetheless, we had to take the same precautions that everybody else has done. So right now, I think the question is not how much we have reduced, but how much are we restarting? I think that's the question all over the globe right now. And I have to agree for the first time with what Cesare said. Usually I don't, but for the first time, I think he made some sense. And so the question is now, how do we restart? How do we safely reopen and come back to business as usual, which it will never be business as usual. But I think the issue is, how do we safely restart? And I'm sure each one of us has a different way of doing it. And so, Helmut, when you're ready for that, I can tell you how we've tried to restart here. I mean, we were down to about, I would say, 10% to 15% of our usual volume, doing only urgent or emergent cases. But now we are up to, I would say, 40% of our volume. So we are gradually increasing our number of cases, watching for that resurgence. But there will be cases as people mingle, as social distancing, unfortunately goes away. I think there will be cases, and I don't see any way that we can avoid it. There will be those, but the issue is, how can we safely reopen our endoscopy units?
And I think this is extremely important because we are all aware that we definitely need to go back to work, because it's not only COVID-19 what we are facing every day in our practice, but we have so many other diseases as well. And as endoscopists and GI endoscopists, definitely we need to treat them. So India is one of the countries with the by far largest population in the world. And it seems at the beginning that there was no problem in India, but now we are learning that even in India, the cases are increasing. So Professor Goenka, what's going on at the moment? And are you changing the practice? Are you also going to some kind of lockdown like the other countries which have been affected before?
So let me give you a perspective that we had our first case somewhere in the February end. And the first few cases were all imported cases, in the sense those international travelers were the only one who were carrying the infections. But now we have evidence that at least in the community, there is some spread which is taking place from the asymptomatic carriers also, though we try to trace all patients for the contacts, but we are not finding contact history in some of the patients. To give you an overall picture, India, is, as you rightly said, is a huge population. 1,300 million is the population. And we have, with all our testing limitations at this moment, about 170,000 patients with COVID. If I have to divide them into those who have been cured, about 45% have been cured. We had a mortality of about 3%, which is a general mortality everywhere. And about 50% of our patients are still active. We had this lockdown, which has gone into 4 phases, and we are now in lockdown fourth phase. And with each phase, there has been change in the policy. At this moment, certain things have opened up. The malls, the saloons, the cinema halls are not yet open. But some of the activity is taking place because the economy, as you rightly said, has taken a back seat. So the whole country has been divided into three zones: red zone, orange zone, and the green zone. And depending on which zone it belongs to, there are restrictions in the different parts. As Pratik said, in India also there is a difference between the different parts of the world, different parts of the country. Mumbai has possibly one of the largest number, and one of the reasons could be the slums which are there in Mumbai, because it's very difficult to control the disease in slums where the resources are limited, people are staying very close to one another. So that's the situation overall. If you ask me what is the trend, I think we are behind Italy, we are behind China, and to some extent behind America, because the numbers are increasing every day. The day before, we had one of the largest number per day. If you look at the first 50,000 cases, which happened in almost 100 days, the next 50,000 happened in 20 days, and the last 50,000 has happened in less than a week. So we are in a phase where we are really worried as to how the things will move.
So we can see we are all facing the large problems with the COVID-19 pandemic. Thank you very much. So what's going on, Professor de Lesson, in the Philippines? What's going on there? So is the situation similar to the other countries? Are you also trying to come back to work and increasing the number of elective cases again? So we have learned from Professor Sharma, most of the procedures has been canceled, but now going back already to 40%. I know from France, for example, they canceled more than 95% of procedures during the peak of the pandemic. So really only absolutely emergency cases have been performed. This is the same like in Germany, by the way. We have done the same. Now we are trying to reopen, but honestly, this is not that easy. So the patients are not coming to us. What's the situation for you?
So again, just like with Italy, we've been in a lockdown for 2 to 3 months already. And our statistics show that we still have a significant number of cases every day. Our cases have hit 15,000 just yesterday. But we remain vigilant. Most of our major cities are still in quarantine, and our government will announce soon if restrictions will be lifted so that the economy may be allowed to recover. And as with most of the countries, endoscopy numbers in most of the centers in Manila, in the entire Philippines, are at their lowest ever. We do probably less than 10% each center right now. And we hope that it will ease soon. But as with Professor Hassan, we should always have our protection protocols in place. Because even if the numbers go down, even if the numbers become zero, I think this will never end pretty soon. This will drag on for a long time.
So we all hope that there will be soon something what is working, either a vaccine or another thing what will help. But definitely we have to come back to normal for our patients and for ourselves. And of course, this pandemic is not only affecting us, it's not only affecting our social life, our family life, our business, it's affecting everything. And we have all been very surprised of this. And I think in January or even in February, we have never expected what we are all facing at the moment. So Professor Ding, you already have shown how we should dress when we are treating patients, even for suspicion of COVID-19. Honestly, it's impossible, at least for me, to scope more than one case, maybe in a full suited case. Yeah, like in a I don't know, in crazy atmosphere. So personal protective equipment has become very rare in Europe. So in Germany, we have not been able for a couple of weeks to use protective masks. Even the goats have been a very big problem. What we have also learned is that propofol sedation is getting extremely difficult more and more, because a lot of patients require the sedation for anesthesia. And therefore, we did not have that much anymore less for our endoscopic procedures. Gladfully, it was never at this case that it was totally gone, but it was, I would say, almost critical. So in China, did you have any problems with personal protective equipment? Because later on, we want to discuss even if we should reuse it, because most of our protective equipment comes from China. So what about your country? Did you have any problems getting personal protective equipment, whatever it was?
Now the PPE is enough in China. So if you want to get, you can get, but you have to pay. Our department, our hospital have to pay for the PPE. You know, several months ago, during the outbreak of COVID-19, everything are paid by our government. So we don't need we don't need to worry the cost, the how much cost of this. So now sometimes we need to consider. So so because the PPE is enough in China now, so we seldom use the PPE now, and because we don't have a lot of case, so so a lot of doctors don't want to get the go to the procedure with the level 2 PPE, because we know the level 2 or 3 PPE can bring a lot of difficulty in the procedure. So I think as to the personal protection, the mask is the most important. The mask and the hand hygiene are the most important. So we use the N95 to protect our mouth and nose, and sometimes use the eye shield to protect our eyes, and the double gloves. I think on this only this is enough. So we don't use the gown to cover the body surface, all body surface now. So I think just this is the more important in the procedure now. Okay.
Thank you.
So Helmut, you're asking everyone. So why don't we ask you about Germany, because Bundesliga has been the first football league to restart the matches as compared to the rest of Europe. But Germany also saw quite a significant number of cases. So how come you've started football before the rest of the world, and is it safe to do so?
And is it very good football?
So I think it's a fantastic football, because German football is a very, very good one. And of course, we open again, and it's a very big discussion in Germany, what we see every day. But also the country has decided, and the government has decided, that it's now going really back to normal life, to a very new life. Yeah, so very careful one. And all the football games are without any attendees. So we have only the football players on the match, but no one is attending so far. But life must go on, you know, and even there is a big psychological problem for everyone staying at home. And at least I think in European countries, even in Germany, it's not, you know, we don't have cities like in US or in China. Yeah, everything is much more wide space. The people are not aware that they have to stay at home the whole time. So it's really a psychological issue as well, that we definitely have to go back to normality. And we feel the same. We don't know what's going on. We all learn every day. And of course, we all hope that there will be no second wave. I'm sorry?
You've restarted the endoscopy there in Germany?
We restarted endoscopy as well. So we are doing elective cases now since approximately 10 days. So since 10 days, we are going slightly back to normal work, although we are really seeing that the patients are not coming to us like before. Yeah, so there's really a problem of the patients sometimes as well, attending the procedures, right, because everyone is extremely careful. So the question is also,
Helmut, yeah. I want to add something about what Zen said about the appropriate use of PPE in China, okay? Because there is a shortage of PPE worldwide. So every country is expected to deal with this shortage as the Chinese are doing. Here in Italy, we have a terrible shortage. For instance, I have only one respirator per day, okay, per all the endoscopy. But my mother can go to the pharmacy and buy 10 respirators that she uses to go to the market. or to meet with other people. So here in Europe, and I guess also in the US, although Pratik doesn't want to admit, there is a crazy use of the PPE that generate an incredible risk on healthcare professionals. China is clever. First, protect the healthcare providers, and secondly, all the rest. Here in Europe,
So
my
Cesare,
mother,
not just
who
the
is Italian,
PPE.
is more protected than me, and also than Pratik.
Right. So Cesare, what I was saying, not just PPE, we also had a shortage of toilet paper here for a long time, you know, so people went and were just buying things like crazy. So you're absolutely right. But I think along with that, what you also have to mention is that it's a balance between the availability of PPE and availability of testing, right? So I think both of those go hand in hand. So like in China, where you have, we heard, if testing is available widespread, then you can adjust your PPE accordingly. So if, you know, when Helmut starts asking us questions about how are you reopening safely, you know, if you test every patient and if they're negative, then you don't need to wear a respirator for every case, you know. So I think there are ways around it, but you're absolutely right. I think it's not just the PPE availability, but the availability of everything else, you know, including testing.
And then one, okay, yeah, but I'm sorry, Cesare, let's go through the list, because everything is otherwise totally confused, and we have over 280 participants, and we're receiving a lot of questions, and definitely we do not only want to discuss by ourselves, but of course we want to give our best to answer those questions from the audience, because we are all facing with this, and we definitely need to answer the questions, and we have only a very short time. So the question is, what is very important for us, Professor Ding, unfortunately we have been interrupted, but you have already said that it's very important to use this personal protective equipment, that there is no shortage, at least not in China. Meanwhile, we have learned from Italy and United States. But what do you think, Professor Goenka? Can we already use the personal protective equipment, or should we do it at least when there is a problem? At least we have learned from Professor Hassan, he can only use one respirator a day. So should we put it in a microwave or at 80 degrees heater and reuse the personal protective equipment? Is there anything what you can recommend?
Yeah. First of all, I think what is important is that we need to use them more rationally. So what we have done in our unit is that we have allowed only one team of endoscopy to work on a particular day. So it's divided between Monday, Tuesday, Wednesday, Thursday. So it's not that different teams are going and doing the endoscopy, so that personal protective equipments are used only by one team. So it's, even if it's my case, I would ask the guy on that day endoscopy duty to do the endoscopy. We don't allow more than 4 people to enter the endoscopy area, so that no trainees are there in this moment in the endoscopy areas. That's also really reduces the need of PPE. As it was discussed, I think masks are the most important one. And fortunately in India has a strong textile industry. And Pratik will know it, in the area from which he comes, Gujarat, has a lot of textile industry. So everybody now is making personal protective equipments, from the automobile industry to a small tailor. Everybody is making PPE, so there is no shortage of PPE. But this also raises the question of whether the quality is maintained or not. That's a very important issue. So what we do in our unit, and I think this is a pretty good way of doing it, is that each one has been given 4 N95 masks. So he will use it by rotation. So he will use it in day 1, and then the same mask will be used after drying on day 5. So with this 4 masks, he can continue for almost 3 weeks and rotates. We know from our understanding that it doesn't remain on the surface. The virus doesn't remain on the surface for too long. So if you use the mask after 4 or 5 days, the mask possibly is already decontaminated. We don't usually do either a chemical disinfection or by autoclaving, but we use this rotation, and we find it pretty useful to reuse the mask in this way.
Thank you. So we have to say, according to the literature at the moment, there is no real recommendation, of course, to reprocess disposable personal protective equipment, although there is some limited data, especially even from US Air Force, what I've learned, and that one can potentially maybe use microwave, ultraviolet, sea light, or something like this. So, Pratik, what is at the moment the indication for endoscopy for you? Are you still, you're saying you're increasing the numbers of cases again? So I suppose that there is elective cases again, but the indication at the beginning was only let's do emergency cases, but now we are at a later stage of the disease. So what is your recommendation for us now, please, for, endoscopy in the pandemic?
Right. Thanks, Helmut. So, for us, our institution has divided the patients into 4 priorities. And again, I think this will be different in terms of the number of priorities elsewhere in the world, however you slice it, but you try to come up with some stratification of your patients. And what we have done is 4 priority. Priority 1 means life-threatening bleeds, so that's priority 1. Priority 4 is average risk screening. So you can see the spectrum of the disease of how you need to do it. So right now, when we had shut down, we were only doing priority 1 patients. We gradually increased it to priority 2. Now we are at priority 3. So that's how we have been able to manage it. So I think, and that is what I can see some questions coming about that. And I think that's how people individually need to risk stratify their patient population and either put them in 3 buckets, 4 buckets, whatever it is, and then try to figure out how they can do it based on the situation of COVID in their country. But we are at priority 3 right now.
Thank you. So you're facing and you're doing endoscopy and research your whole life on and treating and diagnosing early gastrointestinal lesions, Barrett's, colorectal diseases, whatever it is in endoscopy. So what's the situation for you? I mean, you're doing your whole life's research and excellent patient work, yeah, trying to find the early lesions, but now you're seeing, well, what are you offering your patients? I mean, a patient is coming to you and say, Professor Schammer, I have a Barrett's with high-grade dysplasia diagnosed 6 months ago. So what is your response to those patients? Are you saying, well, we have to do it next year? Or are you saying, well, this is a high-risk lesion for us, and now it's time for us to do subsequent therapy?
Right. So I think we did face some of those issues. I mean, the good news is that right now we can get all of them in. The bad news was that sometime the last week of March and in April, we were unable to do that. So fortunately, high-grade dysplasia, large flat polyps in the colon, I mean, I think if you wait a couple of weeks on them, I don't think they're going to die from that disease. So for a time period, we were not able to get those patients in with those kinds of lesions, but now we are able to do it. So just 2 days ago, I mean, we had a patient with a high-grade dysplasia in Barrett's, and one of my colleagues had a large Paris 2A granular, non-granular lesion in the colon, which we did EMR on and resected. So I think we are coming back to that. We are able to use our high-definition endoscopes. We are able to use the virtual chromoendoscopy back, as I think we sort of missed that for a while because these patients were not coming in. What has been impacted is, getting patients enrolled in research studies. So we have a few studies related to artificial intelligence, for example, and being able to try to see how well they work in this patient population. They have been put on hold. So in one way, both us as well as the patients are not able to take advantage of those situations with those kinds of research protocols. But otherwise, most of the other patients we are able to get in now, Helmut.
That's very exciting. Thank you very much. And Cesare, maybe you can comment on this as well, because you're also extremely involved in the development of artificial intelligence in endoscopy. Do you also think that maybe there will be an advantage of novel equipment in this pandemic as well? Can we maybe use, or should we maybe use even more advanced therapeutic or diagnostic modalities, especially maybe even in those times, in order to maybe avoid rescheduling of our patients? Do you see any idea of using novel equipment specifically in this crisis?
Yeah, so Helmut, despite this is a very bad moment, sometimes I have the feeling that I can see some logic. So first, the problem is not only the endoscopy capacity, and I agree with Pratik that we cannot go back more than 50% at this stage, because anyway, you need to leave the room open for 30 minutes. But the problem is patients. Are the patients who don't want to come anymore as they were doing before. So the patients who come, the few patients who come are all for important diseases. So in these days, I'm doing a few examinations, but with a lot of pathology. So the use of high definition, advanced imaging, accurate certification. In these days, it's not reduced. And secondly, in the COVID, you can do only one endoscopy because we have limited capacity, a lot of things to do. So if you do one endoscopy, please do it well. And to do it well is not on you as endoscopists, but it is on all the organization, and it is also on the technology and the equipment. For this reason, if I scope one patient, then I review after 10 years, I want to do with high definition, speed preparation, use of advanced imaging. You know, I like SFI, and I also presented at the virtual meeting of Pratik in Kansas. And so I agree with you. We do less, but we do better. And in this period, we are doing also more than usual.
That's a very important thing. And you're also very much involved in the guidelines over the past year on bowel preparation. And we have different agents for bowel preparations available. Some need a little bit more fluid, some need a little bit less fluid. Would you see a potential advantage maybe of some agents who would need less? So maybe only 1 liter, something like this, specifically in this pandemic situation?
Yes, here in Europe, we are replacing our market leader that was Moviprep with Plembo, that is only 1 liter of PEG plus ascorbic acid, despite very nasty attack by the American lobby. But I must admit that Pratik was the only clever American who was in favor of the 1 liter PEG plus ascorbate. So here in Europe, we are going through a revolution from 2 to 1.
So there might be definitely an advantage in using this because it's even faster for the patients. And then, of course, also the question is, Professor Ding, maybe you can answer this. When we have finished the procedure, what should we do with the patient? Should they go to the recovery room for 40 minutes, or should we discharge them back immediately? Or maybe should we totally avoid sedation and endoscopy during those days that it's not necessary to bring the patient anymore to the recovery room?
Okay, I think now after the procedure, the patient don't need to get more how to say just treat now the patient is treated as the routine procedure. They don't need go to the some isolation room for separated room for more isolation. So, but we have to follow all the patients after the procedure. If they get the diagnosis of infection, I think all the medical staff have the close contact should get the isolation too. But it's fortunate now till now no COVID-19 infection are found after the procedure. So I think till now almost all medical staff and in our endoscopy room are safe.
Thank you very much. And honestly, and Pratik, you asked about the German football, and I'm happy that you all recognize that we're doing football again. But I also advocate that we have to come back to screening endoscopy, especially to screening colonoscopy. In Germany, we have now 8,000 people who had died on COVID-19, which is very, very sad, but we have every year approximately 24,000 people dying on colorectal cancer. And of course, even this is a very high number, what we cannot ignore. So Professor de Lauzon, what do you think? What is your opinion? Should we go back now to screening endoscopy? Would you also advocate to use screening colonoscopy again, or should we wait 2 weeks more, or 2 months more, or 1 year? So my opinion is it's now time, at least for us in Germany, to start again. But what is your opinion?
So our current Philippine Society of Digestive Endoscopy guidelines recommends that we should only start screening endoscopy once the transmission risk in the community is very low, or ideally none. So a large proportion of the population of the Philippines is in Metro Manila, where I work. And the area is still considered a high-risk community, with a case doubling time of about 5 to 7 days. And as such, we do not recommend to start screening procedures yet in our country. And we still recommend emergency and sometimes semi-urgent cases only. This is because, again, of the transmission rate. And it's very difficult to say when will we be going back to screening colonoscopies, as it all boils down again to the discussion of the availability of PPEs. We don't have an infinite number of PPEs in the Philippines, unfortunately. It's a developing country. We do recycle, but we also do what the others do. We actually do cycling of our staff, in which only the minimal, the bare minimum of staff come in, and they work for a whole week, and then they do shifts so that they will not be exposed too much. And we also only do endoscopies without the trainees or the fellows, so that again it's going to be expedited, lower exposure to all the staff. But right now we only do emergency procedures and even just urgent. And screening procedures, I think, might be months from now, because we are still at high community risk of transmission in the Philippines.
No, so thank you very much. And do you think we can go back to normal life this year?
Well, based on our statistics and from the experts that I've spoken to, their estimate is that early next year will be the target if everything goes smoothly, which it never does, really, right? So hopefully they're going to be right, and by early next year we're going to be just normal. But as most would say, they will never that it will never be normal anyway. So let's always be protected, always.
So we experienced that all the major conferences have been canceled. Honestly, all the conferences have been canceled. So I have the biggest hope that at least APW this year will take place. This will be in December, so we can all keep our fingers closed, because otherwise we will only read virtually. And you can't see where I'm sitting because I have this virtual background. And I also do not want to tell you where I'm sitting, because I feel this might be better. But yeah, so this is the new life, what we unfortunately also have. And Dr. Goenka, you are doing a lot of teaching in your hospital as well, and you have performed a lot of publications, even on COVID-19 with your group, even published in GIE. But what to do with our trainees? I mean, are there specific training programs anymore? So honestly, we stopped training in March. So it's not possible for us, even with the low cases and only emergency cases, that basic endoscopy is trained. But there was also no time for us to replace it with online hybrid training or whatever. We just canceled it and we put the colleagues on the ward. So what is your opinion on this? Training for trainees, what's the future in this field?
Before I talk about the training, let me talk about the study which we did last month towards the end of the April. And the figure which we found, we did a questionnaire with 375 people responded, 375 endoscopists of the country. And the figure was, as we discussed, that around 10% of the endoscopies were being done. Now, most of the centers are now ready to do more endoscopy. But as we discussed, it is the patients who are not coming. One, because they have a fear and they want to avoid. But more important than that, for a center like us, we get a lot of patients international from other districts, other provinces. So that with the travel being blocked, they're not able to come. So I think that's one of the major things that we don't look at this opening up very, very quickly. So I think if I'm catering to Bangladeshi patients, they would not be coming to me for the next 6 months. So the centers which are depending on people from coming from outside are going to have a problem. And I think it's, as we discussed, it's not so far as the resources are concerned, whether we are ready or not, but it's the fear of the patient and the logistic problem which is going to decide the volume, at least in our setup. About the training, I think training and research are the two things which have affected the most, and I don't foresee a very quick recovery in this aspect. We have started training through webinars, classroom training. We are also started training through the modules, through the models. But I think we are not going beyond that. The National Board of Medical Education has given us the responsibility of doing webinars on a national level for the that the endoscopy training cannot be through the webinars. We can teach them gastroenterology through the webinars, but to train the endoscopy through the webinars is very difficult. So I think we are in the stage 2, webinars followed by training on the models. I think after that, as the time changes, we will allow them to be trained on the diagnostic endoscopy and then possibly therapeutic endoscopy sometime in the early next year.
Thank you. So you can see we have all a little bit different ways, but we have the same problems, definitely. And also, I think what is a very common question, definitely we will now answer this question, and maybe from all different parts of the world. So from US, from Europe, and of course also from China. And maybe Professor Ding, you can start answering this question. And of course, some of us are doing a lot of cases, some are doing less cases, but at least we're all doing cases. And then the question is, should we screen our patients? I mean, for COVID-19, should we say everyone is positive, or should we say we are only testing high-risk procedures like upper endoscopies or bleeding patients? So maybe you can provide, Professor Ding, Professor Hassan, and Professor Sharma, from the different parts of the world, your vision, if we should really screen now all the patients or only specific population before endoscopic procedures for COVID-19. Professor Ding.
Okay, till now we have to, till now we screen all the patients. So I don't know how, when we can end this kind of screen, because even now I think the transmission, the risk of transmission is very low, but as to the advice of government, we have to screen all the patients in our hospital. So it means we have the low risk of infection by the COVID-19 in the procedure.
Professor Hassan, what's the situation for you? What are you recommending?
Okay, so this is a very important point. I see that there are a lot of questions about testing, and open cross bracket, we will reply to all the questions that are in the chat. So here in Europe, there are countries that have affordability, availability of reagent for PCR. And this is France and Austria. In this case, like Zen said, all patients are tested. So test and scope. You have a swab 2-3 days before endoscopy, and then you go to endoscopy. This is also the policy of the Mayo Clinic, and there is a model on GIE, but I was following very carefully Pratik before, because the idea of the Americans is that I test in order to save on the PPE. Actually,
why don't you respond what's happening in Italy, not in Mayo?
I just read the paper. So in France and Austria, we test. In Italy, we don't have enough reagent to test everyone, but we test in patients. Right. But I see Pratik got nervous.
No. So, I mean, I think what Cesare is saying is absolutely right. I mean, I think it all, again, this is all driven locally as to what do you have available in your unit. If you have a lot of PPE, but not enough testing, then you just consider that everyone is positive and you wear the best PPE. If you have a lot of testing available and little PPE available, then you test everyone and you do that. So I think at the end, this is all going to be governed by what is available in your own institution, not even in your own country. You know, what we are doing in Kansas City is something unique because we have the availability and we have very few cases. So we've set up a drive-through tent in our hospital. So every procedure in the morning, the tent opens up at 5 in the morning. You can go through the drive-through in your car in the morning. You get your nasal swab. They're doing a rapid test, which takes 45 minutes. You go into a parking area, which is for these patients who have just gotten tested. And in 45 minutes, you get a phone call, whether you're positive or negative. If you're positive, you go back home and then you're contacted to try to tell you what to do if you're positive, which is fortunately very few patients. If you're negative, then you're sent to the hospital where you can go up to the endoscopy unit. If you're negative, we are just going to standard PPEs and we are not using N95s or PAPRs or respirators, things like that. But this is because we have the availability of testing.
This is very fascinating, and I think this shows a fantastic US system as well, because this is really, I feel this is the best what one can do. But
Helmut, sorry, I have to interrupt and tell you that this is very different in the US also. And I was talking to some of my friends in Texas and in California, and in many of those places, this is not available. They don't have the rapid testing available. There is shortage of that there. And what they are doing is that they're running endoscopy, just as you mentioned, at about 50%, but they're assuming everyone is positive and they're using the COVID PPE for every case. So again, what I gave you is an example just for us. It's really different throughout the country.
That's very, very exciting. And now we have the great luck really having the major colleagues involved in the American and US and European guidelines here, Professor Sharma and Professor Hassan. And are we expecting new guidelines for managing the endoscopy department in the future? Are you already writing some new articles? Cesaro, of course, your ESGE already gave some advice, but are we really expecting guidelines as well? Or are you expecting maybe in 6 months everything is gone and no one is interested in a guideline anymore? Is a practical advice or a webinar, what we're all doing together here, maybe enough? Or are you expecting that we really have to face a disease for such a long time that we really need validated guidelines as well?
Okay, so Helmut, as you may guess, since I'm not doing too much endoscopy, I'm doing too many guidelines. So I'm already preparing the update of our position statement for the phase 2. And basically, we will say what we said in this webinar. So before coming to you, I was doing a literature search on COVID-19 and endoscopy. And the number of papers that came out is amazing. Anyone is publishing on the best journal of the world. But when then you got to look at the paper, it seemed to go back by 30, 40 years. There's no randomized trial, just observational cases, retrospective cases, expert opinion. So it's impossible to do a guideline. We can do again a position statement based on some feeling. But to do a guideline, you would need good studies. I guess the only good study would come from China.
So yeah, so even in the US, I mean, they really have, all the GI societies have jointly put together what we are calling guidance statements, which is probably the appropriate word rather than guidelines, because as Cesare mentioned, there's really not good evidence to do it. So yes, the American Society for Gastrointestinal Endoscopy, or the ASGE, has come up with guidance statements on how to safely open, endoscopy. And I think a lot of the things which are in the guidance statements is what we have been discussing today.
Thank you. So this is very important. And Professor Delusson, I think we are all aware that every patient with symptoms, well, they should get the test, is it? So with symptoms, test. what are the symptoms? I mean, respiratory symptoms, of course. Fever, of course. We have learned about gastrointestinal symptoms. They're also common in COVID-19. So we also recommend a patient maybe with diarrhea or even abdominal pain should maybe undergo testing before endoscopy. However, I feel this is also very exciting, and this has not been yet discussed so well. We also learned that patients who are healthy, so with 2 times negative PCR results, and without any symptoms, but they have a positive test up to 48 days after. So should we maybe even test in the future patients with a previous COVID-19 infection? Because of course, now we see a decrease in the infection rate in already some countries. So we're expecting more and more of those healthy people. Should we ask in the future, even our patients, had you already COVID-19 in the past? And then we should repeat testing when the disease was within the last at least 50 days?
So that's a very good question. A lot of my colleagues actually ask that question because we have a lot of positive cases becoming positive even after recovery, and we have a lot of cases who are negative and turned out to be positive a few days after. So I think it all boils down to, your testing module or modality, because some would report that the false positivity rates are very high. So I think we should combine our tests with just clinical acumen, just looking at the patient, interviewing him, asking all the questions that you've said about having fever, cough, diarrhea, etc., etc. And if you combine both the testing and those screening symptoms, then probably you can increase your sensitivity. But um, as in the Philippines, because Pratik has mentioned that either you have a lot of PPEs, little PPEs, you have a lot of tests or no tests. Unfortunately, in the Philippines, we have a little of both. So it's very hard to screen our patients. And most of my colleagues will just treat as positive, whatever happens. And this will put a strain on our PPEs because as we treat all of them as positive, it will really just um, uh, the resource will be gone, our PPEs, and thus it's going to be very difficult. And this is also the reason why we also recommend that we only do emergency procedures for now until it improves.
Thank you. And then Professor Ding, maybe you can answer from your side from Wuhan in China as well. Do you think we should maybe test the patients again after they had COVID-19 infection to avoid that they might spread the virus again when we're doing endoscopy? So should we ask the patients, did you already had COVID-19? And when they say yes, we should not say, well, this patient is healthy, but we should screen again.
Yeah, because now we test, I just said, we test all patients for the procedure. So even the patients have the history of the COVID-19 infection, but if the nucleic acid and the IgM antibody are both negative, so we don't think we don't consider the patient as infection. And we actually we did some we did several cases of the have the history of the COVID-19, and we don't think the only how to say the IgG antibody in this patient, the only IgG antibody is positive. So but we don't think this patient gets the more risk of transmission in the endoscopy room. So I think after the nucleic acid and the IgM antibody are both negative, I think it's safe.
Thank you. And honestly, I can say, and thanks again to all of you. It's a fantastic webinar. Thanks so much to SonoScape again in organizing this, but we can see still most of the attendees are with us. So although we are now talking about 1 hour, we can see there are really important questions, and we all have our opinions. But of course, we want to discuss it with you to the best of our knowledge and based on already available data. And I think one question what we have also received now for the last 15 minutes of this webinar is, what about disinfection of the scopes? So should we change disinfection of the scopes? Honestly, it is a virus. It's a very disastrous virus for some of the people getting infected, but at least it's a virus. And of course, it's not the only virus we're facing in endoscopy. And of course, we can treat this one based on our normal reprocessing guidelines. But the question was, maybe Cesare, because you're also doing a lot of work on this specific area, someone was asking, should we now discuss disposable scopes? Even pratique in US, I've heard even disposable scopes are getting more and more important in some parts of the practice. Is this something what we should consider? Or should we maybe say, no, it's absolutely safe what we are doing regarding reprocessing, even thereby giving our patients a lot of trust in the procedure we are doing?
I guess, Helmut, that the second you said is the more appropriate. I mean, if you do a good disinfection, this virus is not a problem. Of course, we did again and again the training on IPC to our technicians who are responsible for the disinfection. We provided with the respirators, but beyond this, there is absolutely no risk for the patient after disinfection of our scopes. So I have nothing against the single-use scope, but I don't guess this is the answer to COVID-19. Maybe it may be to multi-drug resistant bacteria, but not to COVID-19. But that's my guess.
It's safe, huh? Pratik,
Yes,
what are you thinking? What are you saying?
Right, and I think the endoscopy societies have said that in all their statements, is that you should continue with your standard disinfection procedures. And as long as you're doing a good job with it, it will take care of COVID, of this SARS-CoV-2 virus, as well as all the others as well. So just continue with that. I mean, the topic of disposable endoscopes is a whole topic in itself. And I don't think that the COVID should be the reason for you to consider disposable endoscopes.
Mm. And Professor Goenka, from your side, what is your opinion on this, on reprocessing of the scopes or disposable scopes maybe as well?
I think if we are following the standard protocol, there is no need to change our protocol for COVID-19. We know enough now that the same protocol can work. I have a couple of comments to make, and I have a question to Pratik. This rapid test which you talked about, the report coming in 45 minutes, is it sensitive and specific? Because we know that PCR itself can be false negative in about 30 to 40% of the patients. So is the rapid test as good or as bad as PCR? And do you ever, any one of us, use CT scan of the chest as one of the screening modality to rule out? Because in our setup, majority of patients have some finding of the CT chest, which points towards an active disease. I also want, that's a thought process which is coming to my mind, that do we need to change our algorithm in certain situations? We are all endoscopy biased. We want to complete every procedure by endoscopy. But we know that it's an aerosol generating procedure compared to percutaneous procedures. So do we change our algorithm for doing an EUS cholecystostomy to a percutaneous cholecystostomy? Or a difficult ERCP where we cannot cannulate, rather than trying an EUS and trying to cannulate through the EUS, do we give it to our radiology colleague to do a percutaneous procedure?
So Mahesh, I can answer the part about the testing. So the test we are using is close to 99%, has 99% sensitivity and specificity. And I think your question is absolutely right, because given the low, depending on the prevalence, this is one of those in which epidemiology really helps you, and where you need to know the background prevalence of the disease in your population, where the change in the sensitivity by 1% or 2% can make a huge difference in the positive predictive value and the negative predictive value. So it's extremely important. So what we are using is extremely more than 99% sensitive and specific. At least that's what's being tested. And to all the people who are watching is take the test which has been tested in your community and has shown these extremely high values, because there are a lot of these, I want to say, bad tests floating around, which have, you know, sensitivity that they'll claim, which is 95%, but I don't think that's good enough. I mean, I think you should expect more. So Mahesh, that answers hopefully your question to that. The other question about changing procedures, I'm not too much in favor of that. And the reason I say that is because of a couple of things. Number one is transmission with endoscopy, during endoscopy or during procedures, if appropriate PPE is worn, is extremely low. I think on one hand, our guidance statements say that these are aerosol generating procedures. We are concerned even about colonoscopy because of fecal shedding, that can lead to it, but there's really not good evidence that that happens. Now, we just finished a large survey of 250 countries and 2 million procedures. And what we determined in that was that the chances of endoscopy personnel being exposed to the disease was about 10% with these 2 million procedures or so. And this was with appropriate PPE. So I think if we do it right, we probably can still be doing all our endoscopy procedures the way, again, it all depends also on this testing thing that we are talking about and the availability. But I mean, at least in our place, we are pretty comfortable in continuing whatever we are doing endoscopically and not shifting it to IR or to surgery or other people.
Thank you. And I think this is a very important point, what you have mentioned. And some of the colleagues here in the audience also asked, should we fear COVID-19? And I think we should not fear the disease. Of course, we should be aware of the disease, but we should not fear the disease. It's not the first one we are facing as medical doctors in our career, and it will be not the last one. Of course, it's a new challenge, even because it came to us in such a short period of time, and we have been not prepared. We have been prepared with the ESG days or DDW, and not suddenly doing webinars on a disease. Normally, we're experts for imaging or Barrett's or whatever, yeah, but now we have to become experts for a totally different disease, what we have never heard 1 year ago. And therefore, I think fear is not a good answer, but definitely a lot of awareness. And one question was, how effective is to build the personal protective equipment by yourself, and is it effective? Well, of course, we cannot answer it, because how can a study be performed? There is no validation, but of course, I would say everything what at least might protect you is better than nothing what cannot protect you. And at YouTube, for example, and even with the help of the American Society for Gastrointestinal, for example, of endoscopy, with the ASGE, there are some guidelines on how you can prepare some of the personal protective equipment, at least the visor or something like this, by yourself in a few minutes and without huge investments, because this is also what we have discussed early, is getting very expensive for us. And in some healthcare systems, at least, for example, even in Germany, you're only getting paid per procedure. So you're only receiving a specific amount of money for one procedure, but this is covering everything. And no one thought of very high costs suddenly for personal protective equipment. So at least in our country, already many physicians are suffering very hard, and the first hospitals are also already closing because they lost so much money during this COVID-19 pandemic that they cannot survive. But finally, maybe you all can answer me one question. Yeah, please.
So I want to come back to the attendee who asked about fear, okay? And I very well understand your point. But if you send me frontline without adequate protection, I have a fear. So I can be brave if I have all what I need. If not, fear is completely understandable feeling, because anyway, the death rate across healthcare position has been amazingly high here in Italy, and probably also in China, despite. So if I'm not protected, I have a fear, I must confess.
And then finally, I think before we are finishing this webinar, and again, thanks to all of you, it's a fantastic thing. We have never done it before. 6 different countries, different time zones, all one disease. I'm so much interested because I'm personally missing it that much, the travels. And we are normally not traveling for holidays, but normally we're traveling for business and for sharing knowledge, but also to learn, of course, from each other. And during all the conferences, we are learning so much about the new devices. And specifically in this year, we have new AI systems and new endoscopes available. But we cannot visit all the conferences. So how can we spread the knowledge in this field? I mean, we are doing webinars, but do you really feel this is a valid alternative?
I mean, yeah. I think it's we have to adapt with the changing times. You know, we've gone from standard definition to high definition, and now we're talking about AI. So we adapt, right? I mean, and that's what we are really good at doing as humans. So I think we adapt to this, and this is what we are doing right now. Just being on the webinar and listening to what Wuhan did, what Mahesh did, and what happened in Philippines. I mean, I'm learning myself. So I think, is it as good? We don't know that as face to face. They'll obviously, as Mahesh mentioned, there'll be certain things which will be different, like the hands-on. You can't teach people endoscopy on the webinar, but I don't see any reason why we can't impart education through a webinar, which is the same as a face-to-face meeting in a dark auditorium where half the people are sleeping anyway. And I think on the stage we are sitting and we are feeling very happy and proud that, look, I taught 1,000 people, but half were asleep, especially when Cesare speaks. So it's a very different time. But I think we make use of these technologies. We try to do the best we can, and endoscopy will always, or for the most part, remain hands-on, which I think will open up eventually. And yes, there may be a time period that people may get fewer cases, but you'll have more time for teaching. And maybe that one case that you do with a trainee, maybe you'll spend so much time that that's equal to your 5 cases that you used to do before, and let the trainee touch the scope only for 30 seconds before, right? So we have to make sure that now that quality is more important than quantity. And I think this is the time to do it.
And I think also what we are saying and seeing during those days is that we get massive support, even not only by ourselves, but even from the company. So for example, there is a huge social responsibility even of SonoScape. So SonoScape is supporting not only the Chinese doctors, but colleagues in the whole world with personal protective equipment and other things. And I can say it even from Germany, we also get, in the private physicians also get specific support here, for example, only from SonoScape, really for personal protective equipment. So standing together, being strong together. Professor Ding, we mentioned this hashtag in February when we are all live in Thailand, but you are submitting your fantastic presentation online. Yeah, and we all stand up for you and the people of Wuhan. I will never forget this in my life. And in this context, thank you very much again for your very hard fight. It's the very first line. Yeah, but we get a lot of support. And also, I think because it's now time for us to end this webinar, it's very important for us that this was only the first in a big row. So SonoScape is planning many more to come with specific questions and with specific topics, with experts from all parts of the world. And I feel I had a very grateful position today because it was such a great pleasure hosting you all and moderating this a little bit, because it's very difficult and challenging without us seeing each other, because again, we are from all parts of the world facing one disease. Yeah, but you can see we're standing together even in those very challenging times. And in this context, again, I definitely want to thank SonoScape again for organizing this fantastic webinar. And maybe I can ask all of our faculty members again to say a short goodbye to our participants with your personal remark. Professor Ding.
Okay, thank you. Yeah, thanks. I think I know a lot of from this roundtable, and I think is pleasure to get the information and the experience from the all countries. So I think I just thank you and say goodbye. It's hard to say goodbye.
Thank you. Professor Wenke.
Yeah, thank you, Helmut, for organizing it so well. And of course, SonoScape for giving us a platform. I think it was very good. I think when we go to endoscopy workshops, there are two components. One is networking. And I think we are doing a good networking through this webinar as well. The second is to look at the endoscopy workshop cases being demonstrated. I think there also it's a distal learning. Somebody is doing a procedure in the endoscopy room and we are sitting in a hall and there's an interaction. So I think interaction like this can easily replace the endoscopy workshop. Of course, hands-on training is a different ballgame altogether. But thank you everybody for being here and being a part of this webinar.
Thank you. Professor Sharma, Pratik.
Oh, thanks. No, Helmut, excellent job as always is chairing it. As I look at you, I can see you as a CNN newscaster or something, you know, in which you're like managing everything so well. So
so
thank
many
you for
phones
doing
and
that.
everything here. Sorry for this.
Thanks for to Ronan and UF for setting this up. Thank you, everyone.
Thank you so much. Professor Hassan, Cesare.
Yeah, I also thank you, Helmut, and also SonoScape for organizing this. This is not the future, this is the present, and as Pratik said, we must get adapted to it. So thanks, everyone.
Thank you. Professor De Leçon, Mark.
Oh, thank you very much, Helmut. Thank you for all our participants, even our speakers. And I agree with Pratik. You look like a CNN correspondent. So you're very good at doing this. Thank you very much. Thanks, everybody.
Thank you. So then it's time for me to say goodbye. Thank you very much again for attending. Thanks so much to SonoScape for organizing this fantastic event and goodbye. And what we are now saying during those days, stay safe. Bye-bye.
Auf Wiedersehen.